All right, thanks everybody. Hope everybody can hear me okay. First of all, let me just thank the MORE team, the organizing committee, for putting together a great conference, and especially people coming before me. Very hard work, especially during COVID and a virtual conference. I just want to thank you. I also want to thank the governor. What a great aspect to have the governor open up this conference and just kind of give that priority area to not only the MORE folks, but kind of the efforts in Kentucky to address the overdose crisis. Also want to thank Dr. Stack. We just spoke at the statewide harm reduction conference, and the talk I'm giving today is a modified version of that talk. And he really gave a great overview, and I want to kind of build on top of what he said. Also want to thank Connie for those question and answers, really hard questions to answer. You know, there's no right questions, but there's no right answers, but there are a lot of wrong ones. And so thanks for really identifying what we need to do. My talk today is entitled America's Decades-Long Overdose Crisis and the Radical Transformation of the Illicit Drug Market and the Implications for Public Health. What I'm going to do is I'm going to start kind of briefly just talking about national trends, and then, you know, I'm going to kind of skip over the state trends that I usually do because Dr. Stacker did a great job of going over those and going over Madison County specifically. And then I'm going to go in right into my work, my local ethnographic work from North Carolina, working with select communities, and really do a deep dive into how fentanyl and how the fentanyl crisis and the overdose crisis more generally is playing out on the ground. And specifically how changes in the type of drugs that we're seeing in the market, specifically the rise of stimulants, illicit stimulants, cocaine and methamphetamine, along with all the fentanyls and all the fentanyl analogs, are actually changing not only the types of drugs people use and the combinations that they're using, but the behaviors that they're using as well. So how are the different drugs getting in the community? How is that changing people's use patterns and behaviors? And how is that stuff together really addressing and producing health outcomes? Changes in the market, changes in behavior, changes in health outcomes. And that's what I'm going to kind of walk you through today. But, you know, I just want to start with overdose deaths because, you know, the epidemic we know has really created a torrent of infectious disease, hepatitis C, HIV, endocarditis, skin and soft tissue infections, osteomyelitis, and all these pathologies related to mostly injection drug use. But the thing that's been constant, a constant way to measure the mortality of the epidemic has been through overdose deaths. They're very finite and they just affect all of us immediately, as opposed to kind of the longitudinal effects that we see from HIV and hepatitis, where diseases kind of evolve over time and you don't really see the immediacy of it. If you compare 1999, where we had about 16,000 deaths a year, to 2021, where we've had 93,000 last year, if you add all those together, we've had close to 900,000 deaths in the United States, close to 1 million deaths from drug overdose. And just to put that number in context, that's more than all the Americans that have died in all the wars of the 20th and 21st century, starting with World War I, World War II, Korea, Vietnam, Iraq, and Afghanistan. All of those put together don't equal the amount of death we had from from drug overdoses. Moreover, HIV deaths in this country, starting from 1981 until the present day, we've lost about 660,000 people from HIV in the United States. Started 15 years earlier than the opioid epidemic, and the opioid epidemic already has more deaths, more morbidity and mortality related illnesses related to drug overdose deaths. So we're talking about just a real huge crisis when it comes to mortality. And when it comes to morbidity, we don't even really understand the downstream effects of this, because HIV and hepatitis, they're going to come up today, tomorrow, 5 years from now, and kind of, you know, appearing a little later as opposed to the immediacy of overdose deaths. Before I go any further, I really just want to take a second to have a moment of silence. I think everyone on this call has known somebody that has died from a drug overdose, or knows a family that's lost somebody, or a daughter or a son. I've lost a lot of people in this epidemic. I lost my dear friend, Kenneth Cunningham, who was a PhD social worker, and he died 1.5 years ago from fentanyl overdose. So I just want to take a moment of silence. Maybe we can just think of the people we've lost and take a second to do that. So let's take about 15 seconds. Well, thank you for that. It's been a lot of death. And what happens to a community when there's so much death and so much harm in communities that are already suffering from deindustrialization, joblessness, unemployment, poverty? What does it do? All that death. And so I think the collective trauma that we have is something that we need to address, and something that informs and kind of drives this work, I think, from all the folks in Kentucky doing it. Dr. Stack talked about overdose deaths from July of 2019 to June of 2020. We had 81,000 overdose deaths. Now, the year before we had 72. And so before we were going like 70, 71, 72, there was no ceiling, but we were increasing 1,000, 2,000 a year. Last year, the beginning of COVID, we jumped from 72 to 81. That's a huge jump. And if you look from May 2020 to June 2021, we're upwards of 93. So we've already jumped 12,000 more there. And there's definitely a relationship to COVID and the isolation and the a decline of services and people being locked in that has contributed to that. How much, we'll probably never know. But we know it's a syndemic aspect where both the pandemic and the opioid epidemic are interacting to really create higher levels of morbidity and mortality that we have seen otherwise. I just want to take a second and break down the epidemic. I know we kind of talk about this all the time, but it's good. It's just really a background to understand the phases that we're going through. And remember, I said it's important to understand the changes in the drugs and the changes in the drugs that are leading to morbidity and mortality, because they change the way people use, and the way people use affects the health outcomes that they're going to have. And that's one thing great about SSPs. We work with people that are unable or unwilling to stop using drugs. What do you do with that group, right? It's easier, quote unquote, to wait for people who want to get sober or that are compulsory getting sober from prison to treatment. And they're not using anymore, and giving them a list of things they can do. It's a different animal working with people that are actively using. And how do you protect people that are in the throes of their addiction, that sometimes are making okay choices, but sometimes not? How do you protect them from overdosing, right? You can't get sober if you're dead, or from getting a deadly virus that you're going to contend with your whole life. Yes, HIV is now a chronic infection. It's not a death sentence, but you've got to take medication your whole life. It's a burden on you, and it's a burden on the funds that make that happen as well. Infections are very expensive. And so kind of understanding how we can actively engage people that are unable or unwilling to stop using, to keep them healthy as they are in the throes of their addiction, is key. And the first step of that is understanding what they're doing, and how, not only what they're doing, but how they're doing it and where they're doing it. So if we look at these waves here, this is the first wave that kicked it off, is the prescription opioid wave. I hope people can see my cursor. And I labeled it here with the red arrow. And this has started, I would argue it started here in 1996 with OxyContin, but we track it from 1999. And as you can see, death, and this is mortality. This is years here and number of deaths numerically in the y-axis. You can see 5,000 deaths, 10,000 deaths, 15,000 deaths. This opioid wave, the first prescription opioid wave, kind of went and continued to go up. And in 2016, we had 14,000 deaths. And the reason why I'm ending in 2016 is this is a really good figure to show the different levels of heroin and fentanyl and how it surpassed prescription opioid deaths. So you see that was continuing. And actually in 2016, 2017, it starts to take a dip. It starts to go down, prescription opioids. CDC passes their prescription guidelines to educate doctors about prescribing. We've kind of wrapped our arms around the problem of prescribing, of diversion. We know that because pills are more expensive in the community now. It's very difficult to get opioid pills. We have a plague of faux prescription pills that I'm going to get to in a minute, but actual prescription medical pills are harder to get. So we know we've clamped down on supply, and that has had an effect on death. Now, when we were clamping down on supply and the context of people's economic situations, in 2008 and 10, we saw what we're calling the second wave, which is heroin-related morbidity and mortality. And if you see here, we think it started in 2008, and the deaths really started in 2010. But here's the second wave. And look at this. For the first time in history in 2016, we have heroin deaths surpassing prescription opioids for the first time. So the heroin epidemic in terms of deaths surpasses the number of deaths, and that continues onward. So prescription opioids never surpasses heroin and fentanyl again after it's surpassed the first time. And so you can see this in 2010, and in 2013, we have what we're calling the third wave, which is fentanyl. Fentanyl hits the scene. We have an increase in supply from China vis-a-vis Mexico into the United States. Big supply, big increases in use, big increases in fentanyl-related morbidity and mortality. As you can see here, sharp increases in 2016, 20,000 deaths, surpassing heroin and prescription opioids. And these have kept going. Heroin is kind of taking a dip, especially in states east of the Mississippi River, the Northeast, the Eastern Heartland, the Appalachia, Mid-Atlantic, and the South. Fentanyl has really taken over the heroin market, and you'd be hard-pressed to find heroin in a lot of areas. It's all fentanyl, even though it's sold as heroin. Where I do my field work in North Carolina, we're seeing a little more heroin come onto the scene, but it's really fentanyl everywhere all the time. And you can see these in the death numbers. Now, the fourth wave that I want to mention here that kind of only starts to take off in this figure is cocaine and methamphetamine, what we're calling illicit stimulants. Now, CDC calls them psychostimulants and cocaine, and their psychostimulant classification just really involves prescription stimulants, amphetamines, Ritalin, Adderall, but also the methamphetamine cathinones, like the Molly, the MDMA, that have a methamphetamine component to the drug. So psychostimulants incorporate all of those. But let's be clear that the drugs people are dying from are not cathinones, Molly, and prescription stimulants. They're cocaine and methamphetamine. And since the last 3 years, we've seen cocaine and methamphetamine appearing on overdose deaths alongside fentanyl, increases sharply over the last 3 years, and we haven't seen a ceiling on those. Here you have cocaine at 10,000, a little more than 10,000, methamphetamine, a little more than 7,500, and that's in 2016. In 2017, this cocaine goes to about 15,000 and methamphetamine goes to about 10,300. So it's continuing to increase. More cocaine deaths than methamphetamine deaths, just to make a point on that. Yeah, if you could see the numbers here. Now, the thing to point out here is that 90% of all the stimulant deaths in the United States, meaning with cocaine and methamphetamine, also involve fentanyl. And I want to highlight this point. We did a study in Ohio that I presented at the harm reduction conference. I'm not presenting it here. That showed when you control for fentanyl and you take fentanyl out of the equation, the deaths from cocaine and methamphetamine do not increase all that much. We still have a number of deaths. Like if you're looking at the 10,000 cocaine deaths, we still have 1,000 cocaine deaths without fentanyl. But most of them have fentanyl. And what all the data is showing is that the fourth wave of the opioid crisis of illicit stimulants and cocaine and methamphetamine is really driven by fentanyl. And I want to make that point. Cocaine and methamphetamine are not killing en masse without fentanyl on board. And this is really important. Now, cocaine and methamphetamine, very addictive drugs, can lead to social decay, right? Can lead to problems with family and job, but they're generally not killing people the way that the opioids and the other depressants are. And I really want to make that case. So the fourth illicit stimulant wave is important, but it's not on the same level as fentanyl, heroin, and prescription opioids in terms of its driving death. Now, what we do want to ask is, why are people using more stimulants? Why are stimulants appearing on decedents' toxicology panels more and more over the last bunch of years? In order for that to happen, people have to use more. Why are people using more stimulants now? Is it an increase in supply? Is it an increase in use? Is it relationship to fentanyl, relationship to other drugs? Remember, my premise of the talk was that changes in the illicit market in the supply lead to changes in behavior. And these changes in behavior lead to health outcomes, right? Changes in supply leading to increased stimulant use, leading to stimulants appearing on toxicology panels over the last 3 years. So just remember that algorithm as we go on. Now, this is also nationally. I just wanted to kind of show the drugs and the drug combinations here. If you look, this is percentages on the x-axis, and these are drugs on the y-axis. The top here are opioids and stimulants together. And down here are non-IMF opioids and stimulants. So this is all the fentanyl up here, and this is all the non-fentanyl prescription opioids and heroin. And as you can see, fentanyls are appearing and the most overdose deaths. So we said before, I think Dr. Stack said 70% of all drug overdose deaths. And then I expanded that to say 90% of all stimulant deaths have fentanyl on board. So fentanyl is everywhere. It is the ubiquity of the epidemic. And then below that, you have mixtures of fentanyl and cocaine. People using them as speedballs together or subsequently using one and then the other. Fentanyl and heroin together, a lot of time that's from adulteration. It's not people using fentanyl and heroin separately. It's fentanyl in the heroin. And when you ingest that, you're finding both of them on the tox panel. So fentanyl, heroin, and cocaine together. So you're doing cocaine and you're doing a fentanyl adulterated heroin, and they're both showing up. Fentanyl and methamphetamine we're increasingly seeing. And then fentanyl, prescription opioids. Like I said, prescription opioids are always at the bottom now. And that's been 15 years of lessons learned trying to wrap our hands around the epidemic with prescription opioids. And remember, they're coming from legal sources. So we can do PDMPs. We can do other things to reduce supply, educate doctors. With the illicit supply, we don't have that. We don't have an illicit PDMP, right? And we're not going to educate drug sellers anytime soon of the dangers of prescribing and diversion, right? If you look down here without the fentanyls, prescription opioids are still in a good amount of deaths when you remove fentanyl, right? Methamphetamine, then cocaine, then heroin. Now, I want to point out here, when fentanyl's involved, cocaine is used more often than meth. When people aren't using fentanyl and they're just using stimulants, methamphetamine is showing up more than cocaine on deaths. Just an interesting kind of parallel with fentanyl, without fentanyl. Now, the title of my talk, or the subtitle, was The Radical Transformation of the Illicit Drug Market. And I'm standing by that because that is what we're seeing. In my 30 years of doing this work, I have never seen a drug market as contaminated and overdetermined by a multiplicity of drug classes than I have this one. We still have the standard drugs, right? Heroin, fentanyl, coke, and meth. Those are the big four. But within that, we also have prescription opioids. We have benzos, we increasingly have gabapentin, and alcohol. So we still have these other drugs, but the big four are driving this. And within the radical transformation, because we've seen meth, we're just having increases. We've seen cocaine, we're just having increases in supply. What we haven't seen is the fentanyl crisis the way it is now. And as Dr. Stack said, this is driving everything. And I want to be clear. That doesn't mean if we got fentanyl away, we'd have no addiction, we'd have no family and social decay. No. Cocaine and methamphetamine still produce all that. The other drugs still produce all that when people are physically dependent and addicted. But in terms of mortality, we would not see the number of deaths if it wasn't for fentanyl. So here's just an example of this. 2015, 16, and 17, all this data is from the DEA. They collect all the information about drugs that they seize, and they collect information on that, and they put that in a centralized database called the National Forensic Laboratory Information System, otherwise known as NIFLS. You can go there and actually see the drug exhibits that were confiscated by law enforcement, by the drugs, by zip code. Very interesting data sets too. And Kentucky's doing some of this work anyways, looking at crime lab data. But if you look here in 2015, there were 524 seizures, individual law enforcement seizures, right, through arrests of fentanyl. 160 of those were analogs. Out of those, there were 4 distinct ones, meaning, wow, 4 analogs made up of all those 160. There were 4 specific ones. In 2016, it went from 524 to 877 in 1 year. And those are just confiscations. They're a proxy for the illicit drug market, but they're not the illicit drug market. This is our snapshot of the market, because we don't have good relationships with drug trafficking organizations or sellers. So we can't get good data as for what's in the market. The only people we can talk to are cops and people who use drugs, right? They're the ones that are human interfacing with the market. And so since drug sellers are harder to get, even though I've been interacting and interviewing drug sellers as well, low-level ones to get an understanding of supply, law enforcement gives us that snapshot. So that increased 524 to 877. There was 409 fentanyl analogs, so an increase from 160 to 409. Within 409, there were 15 distinct analogs. That's not counting the 4 earlier. So now we're talking about 19 analogs in 2 years, right? Jump 2017, wow, more than doubled. 1,873 fentanyl law enforcement exhibits. These kind of peter out in 19 or 20 because they're so high already. But these are just striking numbers. Look at this, 1873, exhibits 952 fentanyl analogs, 17 distinct analogs. So what is that? 32 plus 4? 36 distinct analogs of fentanyl, along with regular fentanyl, which is known as fentanyl hydrochloride. For you doctors and nurses in the room, the fentanyl that you give in the ER or with anesthesia is a fentanyl citrate. It's a citrate form. The illicit form is not a citrate, it's a hydrochloride. So when we see the 524, the 877, and the 1873, that's fentanyl hydrochloride. And the analogs, right, are the acetonofentanyls, the furanofentanyls, all the different analogs that we have. And if you look at 2017, there was just 117% increase in identification from 2016. So what this means is not only do we have an increase in the supply of methamphetamine, an increase in the supply of cocaine, but we have a massive radical transformation of the opioid market with just a plethora, a panoply of fentanyls and what that's contributing to, and I'm going to talk about this next, is changes in potency that are unpredictable and you can't guess from one day to the next. And it's really hard for people that are using to kind of predict potency and adapt to the market because it's changing so greatly. With a prescription pill, you know the milligram that's on it, you know what you're going to get, you know what you're going to do. With the illicit fentanyls, we don't know that. We didn't know that with heroin either, but heroin always stayed from about 8 to 12% purity. And back in the day, heroin didn't kill too many people. When you look on toxicology reports, heroin was always combined with another depressant when there was a death, whether it was alcohol or benzodiazepines. But fentanyl by itself is killing people on its own. And this just shows you the market and what's going on in the market. So let me kind of transition here to just local trends. And again, I'm going to skip over the state trends. I usually use Ohio to show the supply of cocaine and meth and talk about the fourth wave a little bit. But for the sake of time, and since Dr. Stack went over a lot of the stuff with stimulants, I'm going to just focus on these local trends. These local trends, this is in rural North Carolina for the most part, the foothills region, parts of Greenboro and the Piedmont area. But a lot of analogous dynamics to Kentucky, kind of ruralness and small metropolitan areas, et cetera. So I really think this still holds true for Kentucky, and you'll be able to see some of the patterns and outcomes that I'm talking about. I'm going to talk about data today that is from my NIH-funded FORCE study. And the name of that study is the Fentanyl Overdose Response and Community Engagement Study. It's a 3-year funded study by NIH. It's an ethnographic investigation of the fentanyl risk environment. What does that mean? Ethnography is really just embedded research. If you think of journalists embedding with special forces in a war, it's up close and personal. You're there for a good amount of time. You're really giving a kind of character descriptive understanding of the problem. You're digging a deep, deep hole, but not that wide. So you're really drilling down on a problem, as opposed to more quantification where you're digging a really, really wide hole, but you're not going that deep. You're getting a survey, but not a lot of really descriptive information. I dug a small hole, but really deep, and to try to explore these issues. My main question was, how do these changes that I just described to you, with the increase in stimulants, with the changes in the fentanyl market, with the decline of heroin as the main opioid on the street, how is that leading to changes in drug use behavior? And how is the market influencing behavior and leading to deleterious outcomes and exacerbating the outcomes we already know, the two being infectious disease and overdose, but also I would say, social decay, family decay, addiction, substance use disorders, all the stuff that goes around with morbidity and not just mortality. The methods were participant observation. I was in the field. I wasn't participating in people using drugs, of course, but I was participating in their lives in asking them as they're using, why are you doing this? Can I see that? Can I take a picture of this? I was documenting all the drugs I was seeing on the street and writing up case reports of how much they were, what they cost, how strong they were, what the name for was, where they actually got the drug, the high that it produced, what they liked, what they didn't like, fears, all that stuff around the drug. I got to ask questions as they were using. So kind of in situ conversational interviewing. And then I did more semi-structured qualitative interviewing, formally sitting down with 30, 35 people in rotating cycles to ask pinpointed questions. So my 3 main questions were, how did people who use drugs, people who inject drugs, come to recognize that the heroin market was changing? Let's think back to 2012, 2013, when fentanyl just hits the scene. And who's the first people to really understand and see that? It's people that are using. The police were second, but they're always behind people that are using. So you want to get stuff in real time, you got to be in the field with drug users because they're the first ones experiencing these changes, not the police. My second one was, how did fentanyl impact people's drug use behavior and their health outcomes? Is it different than heroin? What's it doing? Are their injection practices different? Are they going to lead to health outcomes we haven't seen before, or speed up the quickness with which people acquire those outcomes faster? And lastly, what strategies did people employ in response to that? And that last one's very important because, all the tools we have in harm reduction did not come from public health agencies. Public health has always been against harm reduction until it was for it. And that's New England back in the 80s and the 90s. That's California in the 90s and Seattle in the 90s. And it's West Virginia now, pushing back on needle exchange. It's North Carolina now. It's Scott County that Connie just talked about ending their needle exchange. So these struggles have been there for a long time. And it's important to know that people who use drugs invented needle exchange, started in the 70s in Europe, and then during ACT UP movement of the 80s with AIDS, understanding that HIV was injection related and not to use dirty syringes, doing needle exchange underground while public health agencies condemn them. Naloxone, lane naloxone, injectable naloxone, that was invented by people who use drugs as well, not public health agencies. Different ways to respond to overdoses and response breathing and stuff like that. Really just interesting stuff. So what strategies do people employ? And so, respondents over the years identified really 4 main themes where things were changing associated with the introduction of fentanyl. And those are the physical sensations people felt from using the drug, how the drug appeared and looked, the preferences people had for specific drugs changed, and the way they were consuming those drugs also changed. So let's talk about the physical sensations. And I'm going to talk about stuff that I would argue no one's really heard before, not on a level of the conference level, where we're doing a deep dive into what is the fentanyl high actually like? Is it a nod? What's the rush like? Do you get high? How long does it last? What's the outcomes? Can you work on it? Can you have a life? Can you hide your addiction by being high on it to your significant others and loved ones? Is it easy to do that? So let's just start with what we already know about fentanyl. Fentanyl is used in medical settings because it has a very short duration of effect, right? It's fast acting and it comes on very strong and quickly. It's a lipid-based molecule. Heroin and morphine are more aqueous, more water-based. Fentanyl is a lipid-based molecule. It crosses the blood-brain barrier very quickly, almost instantaneous. And so it's leading to a rapid onset and short duration of effect. It's why the anesthesiologist really likes to use it pre and post-op, right? You can give it to someone before they go out and they're going to come off it. You can control it. Well, the illicit version does the same thing. It has a very rapid onset and it has a very short duration of effect. And let's see what people who use drugs, how they describe that. They talk about the rush. It was the first thing that people identified, that the rush was way more intense. And by intense, they mean that they got a really warm sensation in the chest, in the face, in the limbs, but not just the warmth of the opioid high that people crave, almost like a heated upness, like your body was heating up, raising temperature. They would also get a histamine releasing effect like pins and needles. Those of you who used drugs in the 70s and 80s will know, attribute this to morphine sulfate, the pins and needles you get from using morphine. There's been in the literature heroin and Dilaudid producing pins and needles, but really intense, starting at your feet, crawling up your body. And so your head is almost on fire with pins and needles. Also a dizziness, and this is the thing that really kind of freaked people out, was using, you felt dizzy and lightheaded, like you were going to go out. And when people say the minute they did it, they felt like they were going out, this is why. A really intense dizziness. People said they did not experience that with heroin. They didn't feel like they were going to pass out at any second, other than that slow descent into what was called the relaxing heroin nod. And then here's the other scary one, is a chest tightening and a shortness of breath. And so people said that they felt like they were losing air, it was hard to breathe. And this is scary because we know that chest tightening and shortness of breath are portents for respiratory depression and wooden chest syndrome. which we know in the medical literature is a byproduct of iatrogenic fentanyl use in hospital settings, and mostly fentanyl pushes, like an IV push, creates wooden chests where your whole respiratory system locks up and there's nothing you can do about it. You just have to let it pass. Usually in a hospital setting, you're intubated, so it really doesn't matter and you can deal with it. But on the street, if you get rigid chest, you're not going to be able to get air into somebody. And if the naloxone doesn't wake them up, then they won't be able to breathe and it's too late. So if you put all of these together, this is a characteristically, qualitatively different rush than heroin. Now, beyond the rush, the effect, right? So you inject, you get the rush, lasts about 10, 15 seconds, and then the high comes on. What people report is that fentanyl gives a much, much shorter high. And I put 30 minutes here, but some people say that's generous, that the high is a couple minutes. You feel that warmth glow, and then it goes away, right? They describe this as having no legs, that fentanyl doesn't have any legs. Heroin, when you injected it and you got that rush, it was a real bodily high. You felt orgasmic in that sense, to use a colloquial term. And it lasted a long time, right? 3, 4, 5 hours. With fentanyl, you're feeling that warmth, albeit in all those different ways, dizziness and chest tightening I mentioned before, but then it's going away. And this is why when I talk to people, I say, hey, what's your preference, heroin or fentanyl? And they said, to be honest with you, given that the heroin is weaker and weaker these days, a little bit of fentanyl to give me that little oomph for the rush, but then mix with the heroin so the heroin gives me legs, because the fentanyl doesn't last. And if the drug doesn't last, what are people going to do? They're going to use more often. And so here's how a change in the drug supply can lead to change in behaviors with this. What's happening is people are reporting that they're injecting a lot more with fentanyl because they're not getting the feeling. So to maintain the opioid high, you have to keep injecting. This reminds me of cocaine in a lot of ways. Cocaine has a rapid onset and then it dissipates in about 10, 15 minutes when you inject it. So people inject a lot more when they're using cocaine. They binge use. And we know higher injection frequency related to cocaine has contributed to higher HIV and hepatitis C infection risk. And so people are using more. Now, here's the irony. They also say that even though it's a shorter high, the time that they can go without going into withdrawal symptoms is longer. So some people say, although the high dissipates, I won't go into withdrawal symptoms for like 8 to 12 hours. I can go almost a whole half a day without needing to use again to not be sick. If I want to get high, I need to keep using because it goes away. But I can actually not use and not be sick. And we don't know why this is at this point. One of my theories is that the lipid-based molecule stays in your fat cells. It's metabolized slower, so it just sticks around a lot more. This also might be the reason why we're seeing a difficulty in buprenorphine induction with people habituated on fentanyl. The usual time of waiting 5 or 6 hours so you're dope sick before you go on bupe, that's not working. People are coming into clinics 5, 8, 10 hours of not using and going on induced buprenorphine and going precipitated withdrawal. And that might be because of what I'm talking about, just fentanyl staying around longer. So longer time to withdrawal, but much shorter high. Now, the biggest thing that people talk about, and this isn't being talked about, and I want to inject this, so to speak, into the conversation, is the amount of sedation that fentanyl brings. So we often think of heroin and fentanyl as the same, right? They're both new receptor opioids. Yeah, one's synthetic and one's semi-synthetic, but they're generally the same. No, what I'm telling you is they're categorically different. And people recognize that they're different, and they recognize the first time they did fentanyl that, whoa, this is not heroin. And they're so different that people are trying to adapt to that difference. And one of them is the heavy sedation of fentanyl. Now, we think of heroin as being sedative, but I'm talking about sedation like a benzodiazepine sedation, like the purposeful sedation you want to give somebody before they go into the operating room where you're getting knocked out by the drug. And so this sedation is not like the heroin nod. People talk about, nodding on heroin where they feel that relaxed state, their eyes are shut, but they're conscious of what's going on in the room. If you're trying to talk behind their back, even though they're nodding, they'll be like, oh, I know you're talking about me, stop that. Where they're conscious and present in the room, although, they're stoned, so to speak. With this heavier sedation, that's not this. This is being knocked out. It's like bouts of sleepiness. Like what they describe it to me as is like narcolepsy. Right? They're having sudden bouts of sleepiness that they can't control, that all of a sudden they're going to fall asleep. And they're fearing these sudden attacks of sleeplessness, like having a narcolepsy. Now, before, people on heroin, you could work when you were on heroin. We had a high prevalence of heroin use in the fishing communities in Massachusetts and Gloucester. There a high prevalence of heroin use in the construction trades all throughout the 60s, 70s, and 80s. People that do heroin say it gives them energy, that they can focus, they can work. The fentanyl, even those people that are saying heroin gives them energy are saying fentanyl does not do that. Fentanyl is so sedative. I don't know when I'm going to fall asleep, and I can't control the sleep. It just comes out of nowhere. Two quotes on the right-hand side, one from a man of 34 years of age, where he says, yeah, fentanyl, it's warm. If you do too much, it's like a massive rush. And then it's almost like a panic state. And this is that rush that I told you about with the warmth and the pins and needles, but you're getting dizzy and your chest is tightening. And that's the panic state. Oh my God, I can see myself going out. How many times people report that with fentanyl? And this is why, and I'm explaining this to you right now. For the heavy sedation, male, 33 years of age, I did this little sprinkle of fentanyl and it just put me out. I've never nodded out on dope. And we hear this over and over again, that it's just putting you out. The people are going through their day and just falling asleep. Now, Connie brought up work productivity, and Chamber of Commerce is really caring about the opioid epidemic, and they should, because I think fentanyl is bringing a level of dysfunctionality that we didn't see with prescription opioids or heroin, meaning the ability to function, the ability to drive a car, the ability to go to work, the ability to take care of your children, right? If you're falling asleep and you can't control that, that means you can't hide it from your significant other. You can't hide it from your boss. Can you even drive a car? Is it more dangerous now to drive cars because of falling asleep? And so this is a really big concern. And so here's what I said about changes in the market, changes in the drugs people use, changes in outcomes. So changes in the market, now people are using fentanyl more. And what does that mean to health outcomes if people are injecting more? Now, also what I didn't say that is at the end of this slide is that this fear of sedation is what's leading people to use more stimulants. And this is what I believe is the reason behind the sharp increase in meth and cocaine use and why we're seeing 90% of overdose deaths with cocaine and meth also involving fentanyl. Because people that use fentanyl are increasingly using stimulants, and they're using it to fight the heavy sedation. The people are purposefully using methamphetamine so they don't fall asleep. Over and over again, people have talked about how they're afraid that they're going to fall asleep and they need to use meth. If they didn't use meth, they would be not able to control their use. And so you can see how the pharmacology of fentanyl is leading to other drugs being co-used with it, but also how it can lead to health outcomes, higher injection frequency, higher exposure to harms. Increased use of cocaine and meth in response to fentanyl contributes to cardiac, now with respiratory, but also implications for substance use disorders. Now people coming to treat with multiple substance use disorders and not just one. So let me transition to the physical appearance, and this is pretty straightforward. One of the things that people saw in the change is that how heroin looked. This is the common right here, Colombian heroin that was prevalent in the 80s and 90s, powdered form, slightly rocky. This is black tar, mostly found in the western part of the country. Heroin is mostly brownish. Fentanyl can be all sorts of colors. It can be off-white, tan, light brown, and also several colors. We're finding it pink and green and pastel. And the texture is another thing that stood out for people. Heroin is more chunky and rocky. Fentanyl is more like a pharmaceutical, right? It's a pharmaceutical product. It's way more fine. It's like pharmaceutical powder, if you will. And also the taste. When people taste it, heroin has that bitter taste for a variety of reasons. And fentanyl doesn't taste that way. When I ask people how it tastes, they usually say sweet as opposed to bitter. And some people say like a pharmaceutical taste. Let me just give you some pictures here. I've been going around the country taking pictures of drugs and just that radical transformation again. And picture yourself as a user and you're habituated on an opioid and you're trying to figure out what drugs to use, what won't hurt you, what's in what. Very difficult to do these days. This is in Massachusetts. This was heroin adulterated with fentanyl. And as you can see, it's that kind of brownish heroin. But when the person pointed this out to me, he said, there's all these white specks here. And the person that gave this to me was the seller. He was taking care of his friends with this. He said that I take care of my friends because if they don't go to me, they don't know what they're going to get. And with me, they know what they're going to get. And I can keep them safe and they'll be safer. And we're seeing that as well. When people have relationships with the people they buy drugs from, they tend to know more of what's in their product. Unfortunately, lower level sellers often don't know what's in their product, right? Products are packaged way up the supply chain. And so having people you buy drugs from, a lot of times they don't know, which is ironic because there's a bunch of death by distribution laws right now that are punishing people that sell fentanyl to somebody that therefore dies of an overdose. But what that law insinuates is that people have intentionality, or they have a mens rea or a guilty mind, or that they knew they were adulterated, where most of the times they don't. They were just given a package, they don't know what's in it, and they just sold it to somebody. And so trying to figure out what's in your product is an arduous thing to do. This is in Baltimore, they call this heroin scramble. What a great name for it. And it is scrambled. There's been heroin found in it, morphine, fentanyl, and it changes daily. So if the product you're using changes daily, how do you adapt to potency? How do you know how much to use and when to use, right? This is the market. It's very unpredictable when it comes to potency. So it's a moving target all the time. This is just a regular fentanyl product. You can tell by its pharmaceutical whiteness. There was no heroin in this. This was a heroin product that was sold in North Carolina, and it turned green when you added water to it. It wasn't green, it was a white powder. We thought this was like a Breaking Bad, making it green for St. Patty's Day like thing. But no, chemists, colleagues of mine told me that a lot of times the impurities will come out as certain colors when fentanyl is produced, given the impurities that aren't cooked out, so to speak. This is in Atlanta. It was called, the colloquial term the media gave it was gray death. It actually looked like a piece of cement, like a sidewalk got smashed and you picked up a piece of the rock to throw it in water. And it was all fentanyl. There were 3 different kinds of fentanyl found in that. This was heroin, pink heroin, sold in North Carolina. It was sold as heroin, but we tested it and it was fentanyl, a pink product sold as fentanyl. And this is the heroin that's increasingly making its way into North Carolina. It's a tar like the West Coast heroin, but it starts out as a powder. And once you wet it, it turns into tar form, and then it can't go back to powdered form. But this is the heroin that we're increasingly seeing in North Carolina. We've tested a bunch of it with fentanyl test strips, and about 80% come back positive for fentanyl. So there is a very small amount of heroin that doesn't have fentanyl in it, but the chances of finding that and knowing where it is really difficult. This is again where fentanyl test strips can come in, especially testing the heroin, testing the meth, testing the cocaine. Testing fentanyl for fentanyl also has its advantages as well, who I'll talk about in a minute. We're also seeing county fit OxyContin pills. Pills in California, those fake Roxy 30s have made their way into North Carolina. We're also seeing Xanax bars, the 2 milligram Xanny bars, people call them. We're finding those solid fentanyl pills. This is another layer of concern because people using these pills are not expecting fentanyl. They're not tolerated to fentanyl. They might be younger people that are out just for a quick high and they get a pill and they're thinking it's a Roxy 30, but it's not. It's a bunch of fentanyl and it takes them out. We know people have died from this. So just another layer. We know fentanyl is being trafficked in pills now, and we know they're in Kentucky as well. This is cocaine and fentanyl. As you can see, the fentanyl here is almost like a brownish part, and the cocaine, the powdered cocaine, being white, and what you would expect to see from that. This is methamphetamine from North Carolina. This is Mexican source meth. It's important to know that domestic meth production that really was in the 70s and 80s and 90s. And when George Bush signed the Patriot Act and included methamphetamine in the Patriot Act as the most dangerous drug in America, it was really domestically produced. This is Mexican sourced heroin. It's much cheaper and it's much stronger. And it's being trafficked alongside fentanyl. So where you see fentanyl, you're probably likely to see this form of methamphetamine because they're being trafficked by the same organizations. And so what does this mean? How is this changing people's preferences? And so, older people that have started out using heroin, they tend not to like fentanyl for the reasons I said. The rush is a scam. It doesn't do anything. It gives you these pins and needles, makes you all warm, but you get no high from it. You're just using, and then you got to use more and more. And now you're injecting more. And so there's an age distinction there. A lot of younger people growing up with fentanyl don't know anything but fentanyl. I've met people that love the pins and needles and love the rush, albeit they're a smaller number, but they tend to be younger. But even over time, once they try heroin, sometimes they don't even like it. They're like, what is this? And so again, what you're normalized on, what you end up being initiated on, you end up liking that thing. even if generations before you don't like it. So with the heroin and the fentanyl markets in flux, you're going to see this different dynamic of people's preferences. Fentanyl is market dominant in Kentucky, in North Carolina. So the choice whether you want to use fentanyl, you don't really have one. That's the thing about the drug market. You don't have a choice of what you're going to use. And someone texted a question about the demographics with different drugs being used. There are demographic and geographic dynamics. We tend to see cocaine and crack use used more in urban, large, and medium metro areas. And those places are disproportionately populated by people of color, African Americans and Latinos. And so we know that African Americans and Latinos are disproportionate vulnerable to crack and cocaine, where non-Hispanic whites living in more rural, small metro, micropolitan areas, they're more suffering from methamphetamine and methamphetamine use disorder. And that's because the markets have developed there. Cocaine has always been an urban drug. It's king in the Northeast. That's why we haven't seen a lot of methamphetamine in the Northeast, right? Kentucky, North Carolina, Appalachia, a lot of methamphetamine, harder to find cocaine. Where do you go for the cocaine? Louisville, the cities, right? So there are geographic markets, and people living in those areas don't have a choice of what they're going to do. They're going to do what is there. So do I want fentanyl? If I'm a fentanyl user, yes, I do, because that's all there is in a habituated on fentanyl. So if someone asks you, hey, are you searching for fentanyl? Someone says, yeah, I'm searching for it. You might think they're cuckoo. How could you search for that? It's so deadly. There's no other choice, right? You have an opioid use disorder. You're physically dependent. You're going to use what's there until you're ready to go on MAT or to get into treatment. So the market determines what drugs you can do, and then those drugs lend to certain ways of using and certain use-specific harms. The biggest one that I want to share with you is the increased co-use of illicit stimulants and illicit opioids, mostly cocaine and or methamphetamine with fentanyl. We also know that people aren't mixing cocaine and fentanyl together. You're usually a coke user or you're a meth user. And that's, again, not because of choice a lot, it's where you live. If you're an urban crack user, it might be difficult to get methamphetamine. You might not even see it around. So it's not like, oh, I'm just going to switch to meth. So in toxicology reports, we only see about 15% where coke and meth are together. The vast majority, they're either cocaine or meth. But we do know that either one are both being used with fentanyl way more now. And I would suggest this is for proximity. It's just around and people are going to use it. But more importantly, it's because of the heavy fentanyl sedation that people need to work. They need to do life. They cannot be falling asleep with punctuated bouts of sleepiness that they can't control. So they're using meth and cocaine to adapt and basically create the feelings they want. This really shows that people do have agency. Even though they're in the throes of their addiction, they are trying to live productive lives. They are trying to manage their use. Not everybody, of course. We do have chaotic, problematic users, but the vast majority of people I know are trying to adapt. They have habits. They're not ready to get sober, and they're trying to figure out how to stay productive, how to stay alive, how not to descend into that addiction hell. And so these are also things that I think are really important. Two quotes here. 36-year-old male. Heroin's my drug of choice. These days I do meth to counteract the sedation. And what I'm telling you is not my personal belief. These are what people, hundreds of people over the course of multiple years have told me about this. And I'm giving you the quotes here. Fentanyl is so strong that if I were doing it by itself, I couldn't get my head out of my lap. I don't want to be just zonked out. Most people don't want to be. There are people that have really deep trauma that don't want to come out of being stoned because then they have to deal with all their trauma, whether they lost a child to the foster care system, and every time you get sober, losing your child because of your addiction, it hits you right in the head and you don't want to feel that. So you constantly want to get stoned. But most people don't want to be that way. They want to be controlling. They want to be in control of their own lives. And they're already giving up a lot of that with addiction. The feelings that they get from the drug, they are searching for a certain feeling and they will adapt to get that feeling accordingly. The last thing I want to mention with drug preferences is the increased use of gabapentin. And this is really important. We're seeing much more gabapentin on drug overdose death toxicology reports. We know that doctors are prescribing it as a safer alternative to opioids. There's a lot that are getting diverted on the street right now. They're very cheap. They're almost giving them away. They're so cheap. They're the yellow oblong 300 milligram gabapentins, they're being used by people that are using opioids for two main reasons. One is to potentiate the opioid effect, and the other one is to treat withdrawal symptoms. In fact, there's been a couple clinical trials in Europe about using gabapentin like clonidine when people are detoxing to ease withdrawal symptoms. That they're prescribed gabapentin on label for kind of neuropathy and restless leg pain and seizure disorders. So there's a kind of nerve relationship to their pain. So to potentiate opioids like a benzodiazepine, they're working like that. People tell me if they take 2 or 3 gabapentin and they're doing fentanyl, they're really zonked out like they did a benzodiazepine. And there's increasing evidence that they're physically dependent, like benzodiazepines, that people that are using them longer than 2 weeks say it's harder to get off them, and they feel like it's a benzodiazepine habituation. And that's another thing to realize, is gabapentin a physically dependent drug like heroin, like benzos, like other depressants, and the increased prescribing, like I said before. So let me just give a few quotes for people here, and I just want to wrap up in about 5 minutes so we have time for some questions. I think people are using more meth to counteract the fentanyl because it's going to wake you up more. People are, doing meth now with their heroin to counteract the fentanyl, right? And there's a confusion of terms there too, because a lot of times it's just fentanyl, right? But what she means here is that people are doing a meth with their opioids to counteract that heavy sedation. A 36-year-old male, heroin is my drug of choice. So that would be what I would fiend for. These days, the meth I do to counteract the, sedation. And well, just because it's there, right? So I'm doing meth to counteract the sedation, but also because of proximity, right? There's just more of it and it's around, and we're seeing that. So those big 2 reasons, proximity and because they're trying to get a certain effect, but also to address opioid withdrawal. Well, I'll do the meth if I'm sick and I can't find any heroin. A lot of people tell me this as well. They'll do meth and it kind of makes that opioid withdrawal a lot less, even though it doesn't play on the mu receptor. It's not an MAT product. It shouldn't really do that, but people are saying that it does give them relief. And then this 47-year-old male, I just don't do this fentanyl by itself. What I'm doing is so strong that if I were just doing it by itself, I probably couldn't get my head out of my lap and deal with my day. I don't want to be just zonked out, so I do meth to help with that. And these are just some kind of, from the perspective of people who are using drugs, just to get a sense of why people are using. So let me summarize here. What we're seeing is really a rapidly changing risk environment. Most people are unaware of the purity and the potency of their illicit opioids. And this is increasingly concerning with the small amount of cocaine and meth we're seeing adulterated with fentanyl. There is a small proportion of the cocaine and methamphetamine that is being adulterated with fentanyl. And this is really a big cause for concern. I did a study in Ohio when we found over a 6-year period, 11% of the cocaine was adulterated with fentanyl and 3% of the meth. So not a ton, but enough to really give a cause for concern, because if you're just using meth and cocaine and you don't use opioids, that could be a potential pathway for unwitting fentanyl exposure, where you're being exposed now to fentanyl, but unwittingly, not and unpurposefully. Really concerning for overdose. The continuous flow of fentanyl and fentanyl analogs into the drug supply has created an unpredictable and lethal risk environment. And this is for people that know fentanyl, that use every day. You talk to them, it changes in the morning till the afternoon. Buy something in the morning, it's changing in the afternoon. You buy something in the afternoon, it's changing at night. How do you adapt to that? How do you stay safe, even if you want to? This is where fentanyl test strips can help, but within the context of a whole array of harm reduction services to buttress drug checking. Changes in drug use behavior and injection frequency really bode ill for overdose and infectious disease. So like I said before, people are injecting more because the fentanyl doesn't last. Now they're using meth and coke and injecting that. Some people are saying they're smoking their meth and their cocaine because they just can't inject that much. They're already injecting so much with the fentanyl because it doesn't last. So they're smoking their meth and their cocaine. But what we're seeing is a higher injection frequency. And that's really scary, because we know in the literature that the more times you inject per day, the more events you have to contaminate yourself and be exposed to bloodborne infections. We saw this in Canada in the 90s with their cocaine epidemic and how it led to an HIV infection. We saw it in Scott County when people are injecting prescription Opana pills multiple times every hour, and that leading them to HIV, being exposed to viruses more and more. And so we really need to incorporate our hepatitis C, HIV, and disease prevention within overdose, because I do fear we are going to see those downstream effects, and we already are with HIV outbreaks popping up. And remember, they're the same behaviors as that as the fomites for HCV infection, right? It's parental exposure, it's syringes, cookers, injection supplies. So if there's a lot of HCV in a community and the behaviors are there, once HIV gets into that community, especially with the higher injection frequency, that's really the recipe for the outbreaks that we're seeing and will see. Like I said, the increasing presence of fentanyl and cocaine and meth is a really big cause for concern. This is where the fentanyl test strips can really be effective, testing your cocaine for fentanyl. Methamphetamine has shown that it complicates fentanyl test strip testing, that you need more water, that if you don't dilute the methamphetamine, it's too strong and it interacts with the assay chemicals on the strip. So you need about a shot glass full of water, not just a cooker full of water. So if people want to talk about, I have an NIH-funded study on fentanyl test strips right now where we're trying to figure out the best way to give education on how to use them and the struggles people are having. But that said, really good for testing stimulants, but also for testing the fentanyl. There's a lot of dangerous drugs out there that I didn't talk about: isotazatine, xylazine, used as dilutants and adulterants. And so testing fentanyl with the fentanyl test strip can't be harmful, because you want to make sure at least it is fentanyl, right? That it's not a bunch of cut that's going to give you abscesses. We're seeing an increase in abscesses all over Appalachia in the South, from a dirty drug supply, from a really badly cut drug supply. And so the fentanyl test strips can also help test the heroin and fentanyl. And that feeds into the last one, is the presence of toxic dilutants, adulterants, and cut. Big risks for folks. Xylazine has been shown to lead to skin ulcers, but not at the injection site. There's people that are showing up in the ED with ulcers all over their body, like skin and soft tissue infections, but not in the place they injected. That they're having ulcers just punctuated and showing up in random places. And the isotazatine is also a really cause for concern as well. And the last thing I want to say, and I'm going to close up, is the changing fentanyl market and the increased use of illicit stimulants is going to have an effect on how we treat substance use disorders. Someone coming in to a clinic with an opioid use disorder, if we treat that with MAT, they might have a stimulant use disorder now as well. And we don't have an MAT for stimulants. They might have a benzodiazepine disorder as well. And so polydrug use and the changes in the market, I'm afraid, are going to have downstream effects and really affect how we treat people and the multiple disorders people are actually going to come in with. And so I think this feeds into the next talk after me by Eric and Brittany Poe from the training center about the role of peer support and how that can maybe help deal with this dynamic as people look to get into treatment. So let me stop there and say thank you so much. And thanks to everyone that came before me. It's going to come after. It's great. I'm honored to be here for this conference. Thank you.
Thank you so much for being here, Dr. Zibell. We really appreciate your input and the very unique research that you're doing in this field. Do you have time for a few questions? We've got about seven minutes, it looks like. Yep. One question that we've received is with the, and this might be pure speculation, but with the pullout of the United States and Afghanistan, what impact do you see that could possibly have on the drug supply in the United States?
Great question. Yeah, we know that, poppy production with after the American invasion skyrocketed, I think like 1,000 or 1,200%. So poppy production has gone up. Unfortunately for us, Afghanistan doesn't supply the American heroin market. What they call the Golden Crescent, Afghan and its surrounding counties, they feed Europe. And it's a unpure heroin base that they make. It's not water soluble. So Europe, the UK, they get the Golden Crescent, the Afghanistan heroin. It's all landmass all the way to Europe, so they can do that. We get, in the United States, we get most of our heroin now from Mexico, but prior to that, Colombia. And prior to that, in the 70s and 80s, the Golden Triangle, Laos, Cambodia, Myanmar, Burma. And so it shouldn't have an effect, but it will have an effect, I think, on our European and British colleagues. And that's a real cause for concern. So that's how I would answer that. I don't think it has an immediate effect, but it might, just because it is a big change globally.
How is fentanyl represented globally? Is it a similar problem going on in Europe and other countries?
Yeah, unfortunately and fortunately for Europe, mostly the fentanyl crisis is a North American problem. It's Canada, the US, and Mexico. We haven't seen the same fentanyl problem in Europe or the UK. What we have seen in the UK and in Europe are illicitly manufactured benzodiazepines, benzos like your Talizam that aren't on the market, that are really strong. And that's what is contributing to the overdose crisis in the UK right now, and specifically Scotland is hammered by this. It's illicitly made benzos in the heroin. So if you think of fentanyl in the heroin here, think of illicit benzos in the heroin there, and the outcome is the same, right? You're injecting a depressant that's contraindicated with the opioid. And so that's really the big concern for them. But no, fentanyl from now is a North American problem, not a European and British problem.
That's really interesting. So this is going to kind of shift gears a little bit, talking about the individual user level. So you mentioned, you made the comment, how do they know how much to use and when to use? But we'd never really answered that question. So in the field, are there considerations for fentanyl? Are those being made? Is it a test a little bit, try a little bit more later kind of strategy, or what strategies are users actually using to try and avoid that risk if they're aware of it at all?
Yeah, thanks for that question. I meant to include that because I was talking about changes in the response to fentanyl, what people are doing. So thank you so much for that question. Yeah, people are, doing a bunch of different strategies. The one continuum that I've always experienced in the field is nobody wants to die. And, I've talked with sellers too, and sellers don't want people to die either, killing the person who buys your product. So nobody wants to die. Nobody wants to see anybody die. So what are people doing? The ones I see mostly are tester shots, just doing a little bit, whether it's snorting a little bit to see, or injecting just a little bit. The other thing, remember, these are people unwilling or unable to stop. So if you can't get sober and you're using, you can't stop using, these are the things people that are doing, because they're just stopping altogether is the safest way. But if you can't do that, what are you doing? It's tester shots. Also, people are pushing the plunger a lot slower. So let's say it's a full 1 mil in the insulin syringe. You're pushing 0.25 units and then waiting, and then pushing another 25 units and then waiting and going slow like that. We do hear from people that have a hard time finding a vein that they don't want to do that because they're afraid of it slipping right out of the vein. But we've seen this as well. We've also seen staggered injections where someone will use and make sure someone else isn't using while they're there, making sure someone has naloxone on board. The other one is drug checking and using fentanyl test strips. We did a fentanyl test strip study, and what we found is that people that tested their drugs with a test strip were, I think it was 5 times more likely to employ safer drug use behaviors like tester shots, like staggered injections, making sure you had naloxone. In that dynamic. But what was interesting is people with a negative strip, so they found out that there was no fentanyl, still were more likely to use safer injection strategies. And I think becoming aware of what's in your product, what we're finding out, whether you're testing with fentanyl, it slows down the injection episode, makes people think about what they're doing. So after you're testing it and you still find out there's nothing in there, you're still thinking about the harms and the potential and going slow. And so that's another thing that I really see. In drug checking more generally is we're not doing as a community. I grew up in the infectious disease world. And so if we had a Hep A outbreak in the lettuce or E. coli in the frozen fruit supply, we would test everything, right? Find out where it is, what to do about it. We're not testing anything now. We basically have a wild west in the illicit drug supply, and no one's testing anything, right? Where it's left up to the user to get a test strip and test it. We really have to start thinking about local drug checking to understand what's in the community, so we can get information on a feedback loop to tell people, oh, look, carfentanil just appeared here. It's in these zip codes. We have to react to it. So individuals are doing a bunch of different things, but I think it's also on us, the public health community and the treatment community, to think of ways how we can support that. Given the craziness of the market, how can we all together collectively be more informed of what's in the market in the strategies that people can do to respond to it. So I know I got a little off topic there at the end, but I just want to include that in.
Oh, I think that's an excellent takeaway from your presentation today. We have about 1 minute. Do you have any closing remarks you want to make?
The only thing I would say is that, I've been working with Kentucky since 2015 when I was at CDC, and they asked me to be part of the statewide effort to think about how to do needle exchange and giving state guidance. And since then, I think Kentucky's been the model for the country. So many needle exchange, so many committed people really responding. I mean, hepatitis C treatment, removing the sobriety requirement, removing prior auth for buprenorphine, the leadership both at the treatment level, but also with the governor and also with the health commissioner. I'm just really honored to be part of the work you're doing in Kentucky. And I know how brutal this is, all the transference that we feel as workers and all the deaths around us and the pain. And a lot of our communities are struggling with joblessness and poverty and trauma and with COVID and now this. And it also seems like there's no way out. But I just want to say that you guys are doing amazing work. And when I go around Kentucky and I talk to just both consumers, but also people working there, you can see that. You can see there is hope in people. And I just want to say that I'm just so proud to be with y'all doing this work. And I've always been impressed with Kentucky, and keep it up. You guys are a model for the nation, and we need good role models now. So thank you. I'll close with that.